Hello, and welcome to the American Medical Association's webinar examining infection prevention and control in rural healthcare settings. Joining us in this webinar are two centers with a deep commitment to infection prevention. We will hear from representatives from both the University of Nebraska Medical Center and the University of Washington. They are doing great IPC work and both have focused on this vulnerable area of rural IPC. I'm Erica Kaufman-West, the Director of Infectious Diseases at the AMA. 1 in 5 Americans lives in a rural location. People who live in rural communities face higher risks of death due to factors like limited access to specialized medical care and emergency services, and exposures to specific environmental hazards. There is an effort to close the gaps in health that rural Americans have by improving rates of cancer and blood pressure screening, encouraging tobacco cessation and more physical activity, and promoting motor vehicle safety along with the treatment of opioid use disorder. Today, we are going to focus on the gap in healthcare-associated infections. Across America, HAIs occur in up to 40% of hospitalized patients. In early 2025, a study found that white rural patients had a higher rate of HAIs compared to white urban patients. Interestingly, while Black rural patients had similar HAI rate to the white urban patients, they had nearly 2 times increased risk of ICU admission and over a 1.5 times greater risk of death. A few years ago, the National Association of County and City Health Officials conducted a survey among rural, frontier, and small local health departments. They found that less than 1/2 were engaged in initiatives around HAIs, antimicrobial resistance, and antimicrobial stewardship. The majority of these were able to partner with organizations and facilities to collaborate on strategies. Of those not engaging, almost 3/4 noted a lack of funding, lack of staff time, and a lack of training as reasons why they were unable to initiate programs in HAI, AMR, and AMS. But importantly, more than half indicated a desire to partner with organizations in these spheres. We recognize that there are disparities in HAIs in rural areas, but we don't yet have all the information about why that is. We also see that rural healthcare facilities have a desire, but not always the means, to develop well-rounded IPC programs. Today, we are going to look into that intersection a little more. And while we might not have all the answers, I'm hopeful that we'll hear some insights into the challenges, but also see how rural facilities are meeting those challenges. I have a personal interest in this topic. I lived and worked in Southern Illinois for 5 years as an ID physician and director of infection prevention for a small system that included a critical access hospital. We came up against a lot of challenges, and I'm excited to hear how our guests today have contributed to knowledge in this area. I'm joined today by Dr. Ylinne Lynch. Dr. Lynch got her medical degree from Wayne State University in Michigan. She did her internal medicine residency at the University of Colorado, Denver. Her pulmonary critical care fellowship was at the University of Washington, where she then got a master's degree in epidemiology. Also with us is Dr. Liza Rosenman. Dr. Rosenman is an associate professor and director of simulation in the Department of Emergency Medicine at the University of Michigan. She has 13 years of experience in simulation-based teaching and assessment. For the past 5 years, she has been leveraging simulation to improve infection prevention and control practices, and currently has funding to integrate simulation and experiential learning into IPC education. Dr. Lynch and Dr. Rosenman worked together at University of Washington a few years ago, listening to focus groups on this topic and analyzing those discussions. Can you two share a little about those focus groups and what you've learned?
Yeah, thank you so much for that introduction. So, right, again, I'm Ylinne Lynch, and along with Liza, I'm one of the co-leads of the TIPS team, which stands for Teaching Infection Prevention Through Simulation. And we're going to talk to you about some of the work that we did to try and figure out what challenges IPs face when it comes to teaching. As you may have noticed, Liza and I are not infection preventionists. We're both frontline workers. And as such, we know that teaching IPC to healthcare workers is super hard, but it's so important. And our goal with the TIPS team is to really try and help infection prevention educators reach their audience with interactive and engaging tools. Next slide, please. I want to start by just quickly acknowledging all the people that make our work possible. So the CDC and Project Firstline are our funders. Beyond us, there's a whole TIPS team at University of Washington that makes our course that we developed presentable. And of course, we want to thank our focus group participants who are so generous with their time and their expertise. And we were trying to figure out what exactly we needed to focus on with our course. Next slide, please. So we conducted these focus groups really with the idea to better understand the landscape of IPC education across a breadth of healthcare settings. And we really wanted to make sure that we weren't just getting the perspective of people in academic settings, but we really wanted to make sure that we included people who worked in lower resource settings, including rural and smaller hospitals. And with these focus groups, we really wanted to know from our participants, what are you teaching as far as IPC content goes? How are you teaching it? And then what barriers do you find that you have to IPC education, and what sources of support are there for you? Next slide, please. So these focus groups took place in late 2022 and then into early 2023. We ended up with 6 focus groups and 37 participants. And the participants were either IPs or those who identified as IPC champions in their institution. Despite the fact that it was a mixed group, the vast majority of our focus group participants were IPs. 59% identified as working at a rural site, and 49% identified as working at a small hospital. Next slide, please. Once we started to sort through our data, we were really able to categorize most of the data into 5 main themes. And these are the themes here. So becoming an IP, delivering educational content, really the how of it, assessing the impact of the educational content that was delivered, the challenges associated with delivering IPC training, and then the sources of support that our IPs identified. Next slide, please. We're going to focus, thank you. We're going to focus on the 3 that you see highlighted here. So that includes becoming an IP, the challenges, and sources of support. And over the next few slides, we're really going to dive a little bit more into each of these themes. We're going to talk about some of the sub-themes that emerge, and we'll give you some example quotes of what our participants said to support each of these. Next slide, please. So the first thing that we're going to talk about is the theme of becoming an IP. This really talked about how the participants found themselves in their roles and how prepared they felt to do the roles once they got there. So the first sub-theme is motivation, and this isn't really about the motivation that our IPs had to do the work that they did, but really the motivation that drove them into the IP role. And there were a couple, our participants had described having multiple different backgrounds or pathways into becoming IPC. But many of them reported that they sort of fell into IPC for non-clinical reasons, either because of favorable work hours or administrative necessity. Some participants were voluntold in the role or placed in the role temporarily, and then it became a permanent role for them. There were definitely participants that deliberately sought out an IP role for clinical reasons, whether it was because of prior research, clinical, or public health experience, but this was a little bit less common, at least in our sample. And I just want to make a shout out. Although we called this motivation, it's really not about the motivation of the IPs to do the work that they were doing. Everyone we talked to was so passionate about their work as IPs. Next slide. So here's an example quote for this sub-theme. It was just kind of offered up like, hey, do you want to try this? And I thought, okay, that sounds fun. And there's no call. So that was a bonus. Next slide, please. The next sub-theme that I want to talk about is preparedness. So as I said, our IPs that we talked to came from a really big variety of professional backgrounds. That being said, almost nobody reported that their professional background gave them all of the tools they need to be successful in their role as an IP. And regardless of their entry point or prior clinical background, most of them described a lack of formal training or onboarding. And the consensus was that most IPs learn as they go, often while juggling multiple responsibilities and relying heavily on self-education and peer support. Next slide, please. So here's some quotes around the sub-theme of preparedness. When I started, I just relied on some of the knowledge I had from public health, and they, the hospital administration, really just said, make it your own, what you think needs to be taught. And a second quote, it really is learning on the job, unfortunately. Next slide, please. So we're going to move on to the sub-theme, or to the next theme, which is challenges, and I'm going to turn it over to Liza to take it on.
Thanks so much, Ylinne. So challenges, what a fun topic. And indeed, there are challenges. So the IPs we spoke with, they really described burnout, using that term specifically, but other words as well. Overwhelmed, fatigued, exhausted, apathetic. So why is this? And in this theme of challenges, we look at several sub-themes: responsibility, support, audience, and workload, that let us dig a little deeper into where this burnout is coming from. And remind you again, these are challenges related to delivering educational initiatives. We understand that in the IP role, there are many more challenges beyond what we have pictured here. The first subtheme is responsibility, and this one's pretty straightforward. This is the idea of you're responsible for something, but maybe you didn't have the ownership for it. IP said, yeah, I have to do this thing, but I don't get to decide the when or the how, and the frustrations and challenges that come with that. Next slide. Support as a sub-theme, or in this sense, challenges the lack of support. So many IPs reported limiting training of their own on how to teach others, how to reach adult learners in their educational delivery. And this kind of coincides with that first theme we saw about how people became IPs, right? If you fell into that role, so to speak, you may not have an education background or an IP background or anything relevant potentially, or that feels relevant in the moment. And so this idea that I don't actually know how to do the job well that I want to do. And then IPs reported that IPC training was frequently under-supported by institutions in terms of personnel, time, physical resources, and training. And specifically, the lack of personnel support was really frustrating to IPs, and that it made them feel overwhelmed and alone in their attempt to deliver a vast quantity of content across many settings. And then finally, the idea emerged that it's really the onus is on the IP to make the return on the ROI, the return of investment, obvious to the institution. That there's many times institutional leadership isn't familiar with the value of IPC, and so the IP had to demonstrate their own worth. Next slide. So some quotes related to this. I could tell in the beginning that maybe I was hired in my role just because they had to have an infection preventionist, and I had to just show what my value was. That came over time when we were responding to an outbreak. Nothing like an outbreak to show value. And then the second quote, just having the equipment to train with is sometimes very difficult. Next slide. The next sub-theme we want to talk about is audience. So these are the healthcare workers, the staff that the IPs are trying to reach when they're teaching. And within the sub-theme, staff turnover, misinformation, competing demands, there are several things that can contribute to challenges here. IPs felt like they met with resistance from the healthcare workers that they're supposed to be training. And they recognize that this came from a variety of reasons. It could be disinterest, it could be turnover, it could be the misinformation issue. It was interesting that IPs really demonstrated a lot of empathy towards the frontline workers about how the frontline workers are also feeling burnout and competing priorities, and how challenging it made it for them to be active recipients of this knowledge. IPs also described frontline workers mistrusting the system, the process, but also the IPs, and how frustrating this is as well. And this was attributed to the fact that the guidelines are, but especially then, really rapidly changing. And so it undermined trust there. And then also now this abundance of misinformation that people have ready access to contributes to that mistrust. Next slide. Some quotes related to this. We're having a lot of trouble with staff retention, which means that our amazing staff that stick with us are having more and more put on their shoulders, which is hard. And you're talking to care staff who have been working, 60, 70 plus hours already, staying late on a shift. They're just trying to get through caring for someone with a higher ratio than normal, and you're trying to talk about hand hygiene. So again, I think this really shows, yeah, it's frustrating for the IPs, but also they had empathy around why this was happening in this particular situation. Next slide. The last sub-theme within challenges is workload. So, in addition to feeling under-resourced frequently, the IP role is just intrinsically difficult. So IPs have to deliver a variety of content. You have these diverse learner groups, and you have to create content that is culturally sensitive, that is appropriate for different professional backgrounds, that is relevant. And then you have these changing guidelines, so you have to update them all the time in order to stay on the mark. Compounded by compounding this fact is that IPs serve different employee roles or different groups within the hospitals. So this could be employee health or patient safety. So especially in rural settings, right? You know, people talked about wearing many hats. Next slide. So we have quite a few quotes here that we thought were really interesting and spoke to some of the unique challenges that are in rural settings that maybe our academic centers either aren't facing or have more support with. So first, most of the people that live in the city are Native American. So a lot of our problems or challenges relate to traditional medication versus the Native American medication and how they go about treating their illness. So sometimes I have to, before my presentation, find out which tribe they're coming from, and I try to incorporate some of that into my training because there's some things that they don't do that we do. And second, some of the individuals that I'm responsible for teaching IPC to don't speak English, and we rely a lot on translators that we have within our organization to provide some assistance there. So certainly additional challenges. Next slide. And then related to those, the sub-theme, within the sub-theme of workload, this idea of competing demands. So my title is quality manager, but I'm also the risk manager, which becomes infection control. But I also run the mobile clinics. I run the outreach team. I write grants. So it's pretty impossible, basically. Let's put it that way. And lastly, so it's really trying to train enough people to help supplement me. Because if I don't, it's all me. That's who IPC is, just me. So I'm not sure if this quote or some of these other quotes resonate with people attending today, but I think it really emphasizes just how hard it is to be an IP, and especially to be an IP in a rural setting. Next slide. That being said, we really want to end on a positive note, and that's actually easy to do because the IPs that we spoke with are so positive and so passionate and so hardworking and so creative that it's really able to still see the light after getting through a conversation about challenges. So our conversations reveal just how much IPs support each other, and this could be in a kind of official capacity through organizations. APEC was called out multiple times for being a source of material, trainings and whatnot. So professional organizations, but then also this unofficial, self-made networks that IPs, if you're the only IPC at your site, but there's someone at a small critical access place not too far away, that might be 100 miles, I don't know, but someone you can partner with there, and really how supportive IPs were of each other. Next slide. I also was able to go to another critical access hospital nearby and shadow their infection preventionist there for a day. That was super helpful. She'd been an infection preventionist for like 20 years, so she knew her job inside and out. Also, just networking with other IPs in my state and kind of learning what they do, what works for them, what hasn't worked for them. So that would be that informal networking that people are doing versus I really leaned heavily on all that, conferences, webinars, the APIC roadmap. Next slide. So that's of the three sub-themes we're going to talk about today, that was it. Becoming an IP, challenges, and then support. We do want to acknowledge that there's limitations to the work and our findings, right? This was done in 2022, and likely some of our conversations were influenced by the proximity to the COVID pandemic. Inevitable, it has changed the landscape for everyone. Also, our participants were self-selected, so certainly some potential for selection bias there. We're probably getting the eager, motivated people who were willing to donate their time. And then also, you know, I don't know, human nature or not, this tendency to maybe talk about challenges more than we talk about some of the positive things. And so our work here might underrepresent the facilitators to providing good IPC teaching that are actually occurring out there. And then the last one is, again, a reminder we were focusing just on the provision of IPC training. So not so much a limitation, but just what our goals were, what our questions were when we set out to do this. Next slide. So some final takeaways. You know, recognizing that IPs represent a really motivated and creative workforce, but that they're also at high risk of burnout and frequently feel undersupported in their roles. And that additional training and mentorship and resources, especially those directed towards early career IPs, has a potential for really big impact. And on that note, I think transitioning to our colleagues at University of Nebraska, who have done really incredible work at developing and disseminating resources for IPs. Thank you so much.
Thanks, Dr. Lynch, Dr. Rosenman. It's been really inspiring to hear how people got creative and resourceful in getting the job done. As you mentioned, it can lead to burnout if people are left on their own to try to figure it out for themselves or develop education and policies from scratch. Now, as you said, we're going to hear from two experts at the University of Nebraska Medical Center who have been working with rural IPs, doing needs assessments and helping support them with tangible products. So the first is Lauren Musil. Lauren is an infection preventionist with a background as a registered nurse. As an infection preventionist, her focus has been in critical care, oncology, high consequence infectious diseases, and ventilator-associated events. She leads development of infection prevention education, resources, and tools to support IPs and healthcare facilities. With Lauren is Alisha Sheffield. Alisha graduated from UNMC's College of Nursing and began her work as a nurse in the operating room and perioperative area. Her work at the surgical center progressed into running the IP program with a focus on disinfection and sterilization. She joined the Nebraska Medicine and Prevention team in 2016 and served as the liaison for the ambulatory clinics, high-level disinfection, procedural, and inpatient areas. She earned a Master's of Science in Nursing at Clarkson College. Thanks both of you for joining us today, and I'm really interested in hearing what you and your team found out about the needs that these IPs had and how you helped fill them.
Great, thank you so much. We can go to the next slide, please. So to kick us off, we just wanted to briefly share how this work came to be. As our colleagues on the call already shared, the COVID pandemic clearly highlighted challenges and a lot of vulnerabilities with IPC practice and infection prevention programs in U.S. healthcare settings, particularly in rural and critical access settings. We also receive funding through a number of CDC grants and through Project Frontline. And our team over the past 5 years has worked to develop education, tools, and resources targeting at identifying innovative approaches to address these IPC vulnerabilities and to support good IPC practice. Next slide, please. So one of the first steps we took was to perform a needs assessment to ensure that we were making informed decisions as we set out to develop these tools and resources. Our team is comprised of IPs and IP adjacent roles, so we felt that we knew what our reality of infection prevention challenges were, but wanted to ensure that we were validating that what we considered to be priorities was actually what other IPs were also experiencing, both in our region and in other parts of the country. So we actually performed 2 needs assessments, the first being a small targeted assessment within Region 7. So that included many rural facilities throughout Nebraska, Iowa, Kansas, and Missouri. And that needs assessment focused on education and resource gaps. Our team can put the link into that journal article in the chat just in case the results of that needs assessment are of interest to anyone on the call. But we will also be looking at our second needs assessment results today. So this needs assessment was of larger scope and was performed last summer. And it really looked for IP insight on their professional relationships, IPC concerns, and ongoing education and resource needs. Next slide, please. So a more in-depth look at these needs assessment results is available on our website, and you can access that through the QR code. But for the purposes of today's presentation, we wanted to focus on items that would be relevant to this group. So this needs assessment was distributed to IPs across the country who worked in all types of healthcare settings. We had 267 respondents to our assessment, and this page just displays the demographic breakdown by IP experience and also the various facility sizes that these IPs were responding from. Next slide, please. Some of the results that we found very interesting, and again, similar to our colleagues related to IP education and onboarding, 61% of our IP respondents said that they received IPC specific orientation upon hire. And of that 61%, only 44% felt that it was adequate. The image on the right also shows the frequency of respondents who serve in multiple roles in addition to being the IP. And really, it is no surprise that we see our smaller and critical access hospitals having their IPs covering more additional roles like quality, occupational health, safety, and then many are still working on the floor in addition to performing their IPC duties. Next slide, please. So we were very interested in assessing how IPs felt about their job satisfaction. Our needs assessment found that 41% of our total IP respondents served in multiple roles. The overwhelming majority of that state that serving in multiple roles contributed to their job stress. Some also said that they have considered leaving the position due to that job stress. Of those who served in multiple roles, they have considered leaving their positions, but some also stated that it contributed to their job satisfaction as well. There were also other key takeaways from our needs assessment, but again, for the purposes of today, we really wanted to highlight one that we felt was very profound, and that there was a significant correlation that IPs were more likely to enjoy their jobs when they had a positive relationship and support from their hospital leadership. And again, more in-depth breakdown of all of the results we received on our website if anyone is interested. Next slide, please. So our needs assessment results really help to reinforce our IPC innovation model that we have coined as the IPC Support Center. The development of this was intended to act as an IPC resource hub comprised of tools, education, modules, webinars, IP forums, templates, and other resources, all with the goal to support infection prevention programs, IPC education across healthcare facilities, and then to facilitate best practice for infection prevention, and ultimately to support the frontline IP, especially since many of our IPs in small and rural facilities are lone IPs. So wanting to make sure that we're really able to support them, knowing just how thin they're spread in their facilities oftentimes. And so we will dive into each of these projects over the next couple of slides. Next slide, please. So the first tool I will talk about is the SLICE tool, or Self-Led Infection Control Evaluation Tool. SLICE is a free online self-assessment tool that allows IPs to perform a self-evaluation of their IPC programs using standardized criteria to identify priority areas of opportunity. Its initial development was targeted to rural and critical access acute care facilities, and you can see all of our currently available domains in the table on the right. Our intention in developing the SLICE tool was really to empower those frontline IPs, particularly lone IPs, to evaluate their programs and make data-driven improvements based on the results of their assessments. Next slide, please. We have received overwhelmingly positive feedback about the SLICE tool, with 96% stating that the summary reports provided a useful guide for making changes and improvements to their IPC programs, as well as the majority stating that the domains were applicable to their programs, that the resources were helpful, and that the results helped them to identify those gaps in programs. Next slide, please. What we really think sets SLICE apart from other programmatic assessment tools are the summary reports and the ability to track your performance. This is an example of a PDF summary report where it shows how you performed on the assessment, where points were allocated, where you fell on the performance threshold, and specific resources with links to support the questions asked. Next slide, please. SLICE also offers the ability to track your assessment performance over time. So you can see in this example, you have the ability to compare results to a previous assessment to see how your program is performing in comparison to the established thresholds for each assessment topic, which makes it a valuable tool for any performance and quality improvement interventions you may be taking through the IPC program. And with that, I will turn it over to Alisha to review the rest of our resources.
All right, thank you, Lauren. Next, I wanted to chat a little bit about our XR, or Extended Reality Education Program, for specifically the sterile processing environment. So this immersive simulation-based tool helps IPs to really familiarize themselves with the sterile processing workflows before they even enter the actual sterile processing space. A lot of IPs that we've talked to report feeling very uncertain or even out of place in this specific area, and it makes it really difficult for them to effectively assess the area. So the XR module helps to bridge that gap by building some confidence and providing a real foundational knowledge in a pretty much risk-free virtual setting. Our XR education content can be delivered in a number of ways. There's an immersive headset, which is the preferred way because you can really feel like you're standing in the space. But you can also complete this education on a laptop, a tablet, or even a smartphone. We currently have 3 tiers of modules. We have the novice, intermediate, and advanced. The novice covers the decontamination and clean room. The intermediately steps it up a little bit to looking at specific devices and performance monitoring. And then the advanced module actually steps the IP through the process of a failure event and what they would do. Next slide, please. This here is a quick glimpse of the laptop view of the beginning section of the novice module in decontamination. Using this space, the module takes the user through some areas that they would see in decontamination and walks them through the process of donning necessary PPE, looking at some case cards that have been returned from surgery, and beginning the manual cleaning process, all while providing education along the way. Next slide, please. Another very popular resource that we have developed is our Behind the Mask webinar series. And this idea was actually started from our efforts to provide consultative services to IPs in the small and rural critical access areas. We spent a lot of time with different IPs across the country, and we really found that a lot of them were asking the same questions. And so we thought, wouldn't it be amazing to provide a way to reach hundreds of IPs instead of just one IP at a time to answer some of these questions? The series topics are created to coincide with the SLICE domains. So IPs could essentially take SLICE, and then if they needed assistance with a domain, they could listen to our webinar that supports that specific domain. We cover a large variety of topics, all the way from HAI prevention programs to EOC rounding and really everything in between. As you can see from when we started back in January of 2024 till now, our audience has really grown to about 500 participants each webinar. So a lot of really good information. If you haven't joined one of our webinars, I encourage you to scan this QR code to get registered because it really has proven to be a valuable tool for a lot of IPs. Next slide, please. Another really great opportunity that our team offers is what we call office hours. So along with our resource development, it was really important to our team that we did not lose our one-on-one connection with the IPs, our ability to talk with them and hear what's going on in their everyday. These office hour sessions are hosted every other month for a full hour. And then they're also hosted immediately after each of our webinars for about 30 minutes. And we really use this time to discuss questions that IPs have or struggles that they're going through within their facility. It gives IPs a chance to hear how others are tackling issues too, and then to allow a platform for people to share their success stories so that others may learn and glean some knowledge from that. It's really been a phenomenal learning experience for our team and I think for others across the country. Next slide, please. Our next resource has been highly anticipated. It's probably one of our most anticipated resources at the moment, and it has been under development for almost 2 years. It's scheduled to go live actually this month, within the next week or so. We call it our 90-day survival guide, and it's a comprehensive resource that's designed to support those newer IPs with the main items that they need to know in their first 90 days on the job. I know our team and our other colleagues have talked about IP turnover, and a lot of IPs are thrown into their role and that's not their job, it's not their background. So how do they even learn what they don't know? Each topic in the survival guide focuses on the categories, providing a background to the topic at hand, discussing how each topic relates to the IPC practice. Each topic, we provide some practical strategies and tools that are relevant to the topic and really step the IP through the thought processes and questions that they need to consider as they address each element. Finally, we provide them with some key resources that they need to understand the topic. I think a lot of times IPs, especially new IPs, get overwhelmed with all the resources out there and really deciphering which resources are based on evidence-based practice, which resources are opinions. So we kind of guide them through that as well. Next slide, please. So it's essentially a 12-week journey that follows a really structured, intentional path, which each week builds on the knowledge that was gained in the previous week. So the topics guide infection preventionists through the key concepts from understanding their role at the very beginning to walking them through different healthcare associated infections, to core processes like hand hygiene, personal protective equipment, and even touching the subject of interdepartmental collaboration. Additional topics we cover include construction, notifiable reporting, waste management, environmental services, really just to name a few. When we finish the guide, the IP should really have a solid understanding of their role in development of a robust IBC program, and hopefully have the tools they need to really implement some successful strategies. Next slide, please. And then finally, I wanted to tell you about our resource repository. So as we've collaborated with a lot of IPs, they have told us, I really wish I had something like this, or, if we could just find a tool that would help bridge this gap, especially like as a supplement to our webinars and things like that. We started developing some really targeted resources based on the feedback from the IPs, from the webinar, from our office hours. So this resource repository has a mix of resources, templates, audits, checklist, all organized by topics. Currently, we have 42 resources available. That list is growing every week. And we already have over 6,000 downloads since we started tracking our downloads. So it's a growing tool, ever-changing, and it really helps the IPs not have to reinvent the wheel every time they need a new resource. Next slide. So as you can see, we really have developed a large suite of resources that have really proven to be extremely helpful to the infection preventionists across the country. We are always looking for more tools to develop and more resources to make. So if there is something that, as you're listening to all of us talk and you're thinking, man, I really wish we had this tool, this would be so helpful, we would love to hear about it. We would love your feedback. So that's all I have. Thank you.
Thanks, Alisha. Thanks, Lauren, for sharing all those resources. It's good that you mentioned asking for more resources, because Melinda, one of our viewers, wanted to know if there were any resources that cover correct scope cleaning processes. So I don't know if that's one that you guys have, or if that's one that you know of where you can point her in the right direction, but that's one for sure that is coming up today.
We do. And fun fact, our webinar that is coming up on a week from Thursday actually goes through high-level disinfection, semi-critical device reprocessing. So I encourage the listener and anybody else who's struggling in that area to attend that webinar, because we're going to dive deep into the IP role in device reprocessing.
Oh, that's fantastic. It's such a critical area where, a lot can go wrong, and there can be a lot of downstream consequences. So happy that you guys are focused on that, and that our listeners and viewers can also take advantage of that. So thank you guys. So again, for this part of the webinar, we're going to address some questions that you guys have asked in registration, and the other ones that come through in the chat. The next question I want to ask, I'll address to Dr. Lynch, but open it up to anybody else. Do you have any suggestions for helping administrators understand the importance of devoting resources to IPs? Whether that's something that our IPs can give to the administration, or just a way to present it where they understand the value and the necessity of supporting the IPs.
Yeah, we talk a lot about this actually with our IPs in our course. I think a lot of times when we're presenting to other adults, one of the main characteristics of adult learners is they got to know the why. And I think what's really hard about IPC is that when it's done really well, the value is a little bit invisible. You can't really easily measure the HAIs that are prevented. And so I think one of the things that can be really helpful is having, for whatever you are trying to make a pitch to your administrator about, have that elevator pitch ready. Don't wait till you're in that meeting to sort of break that out. I think practicing that a little bit and having a chance to really emphasize that why, your reason for why you need something, why you need an additional resource, why you need additional personnel, will be really helpful. The other thing that we talked a lot about with our participants in our focus groups, and that we talk a lot about in our course, is that IPs collect a lot of data already. So there's a lot of time spent collecting data about what they're doing, their program. And I think a lot of that data can actually be turned around and used as an assessment, either for the training they're doing or for something else. And so finding a second use for that data where you can try and demonstrate the value of what you're doing. can be really helpful.
Thanks. Dr. Rosenman, anything to add to that?
Yeah, I think that one other thing we've talked about is finding out what other institutions are doing, right? So sometimes that can be a motivator, that competitive factor. If you go to your institutional leaders and say, well, you know, that the next town over or across the street or whatnot is doing this, and these are the results they got. So building on the network that IPs already create for themselves. And if you find someone already doing it, leverage that.
Great. That sort of takes us into the next question that one of our viewers had, and I'll pass this one now to Alisha and Lauren. How do you recommend that rural IPs or lone IPs reconnect to the larger IPC community? I know that that was one of the pieces of your of both of your groups' algorithms, was trying to get support from outside of just, you know, yourself as that individual IP. So what do you recommend that these lone IPs can do?
I can start, Lauren, and you can add on too. So, you know, there's definitely the easiest way is through the APIC chapters. They're everywhere, and they're filled with IPs who have this similar questions. And you know, connecting through some of those groups. There's one in every, I believe, one in every single state, maybe multiple in every single state. So touching base with IPs there, but you know, also within your small community. I have found success in cold calling, you know, the hospital IP, you know, down the road or whatever, and introducing yourself and putting yourself out there. You know, there's lots of support within this community. It's everybody's rooting for one another. So, you know, I think getting a call from another facility saying, hey, you know, let's collaborate, let's network, would bring a lot of success. And then obviously through our office hours is intended to create some networking within the IP community as well.
Yeah,
Great.
just to add, you know, I think another great opportunity that's often overlooked is tapping into your resources and your state and local public health. Those are really valuable relationships that you can develop. And so I know a number of state HAI-AR program coordinators facilitate IP hours like quarterly or something. I know, for example, the HAI director in the state offers a lot of infection prevention courses and webinars and such. So I would definitely make sure you're looking to partner with some of your public health colleagues. And then, you know, a lot of states have really robust like healthcare coalitions and things like that. So certainly don't miss that opportunity. And, you know, often I find you, especially in rural and critical access settings, that your hospital leaders are often tapped into those resources too. So worth making, seeing if they have any relationships there that you can tap into.
Great advice. Thanks. We have another question from one of our viewers today. Her name is Gretchen, and she wanted to know if there are any tools or that would help in sort of those hospital adjacent facilities, whether that's skilled nursing facilities or congregate living areas. Are any of the resources, Lauren or Alisha, that you guys developed, can those be modified, or perhaps they already are applicable for those other types of settings?
I will say we've not created any specific resources for specific healthcare settings. Alisha and I say this often is the overwhelming majority of infection prevention practice is the same regardless of facility type, but it's really important to understand the nuance of your facilities. So long-term care, for example, you know, those residents are living there or are there for very long periods of time. It's more of a congregate care setting. So all of our resources are intended to be modified to meet the needs of your facility. So please take our resources and manipulate them however it helps you best. And then I would also say that the CDC has done a lot of great work in Project First Line on developing tools and resources for to look at infection prevention practices in ambulatory settings, long-term care settings, and dialysis, dental, things like that. Alisha, would you add anything?
Yeah, I agree with you. You know, the basic thing is, you know, safe injection practices that are safe at an acute care hospital are also safe at an academic medical center, and they're also safe at a dental practice. So a lot of the stuff translates between facilities, and it really is the nuances and the specific guidance and resources for some more nuanced and specific settings that people are missing.
And I mean, just to throw it out, you're always welcome to reach out to us if you're like, oh my gosh, I'm just so stuck. Our office hours are really a good forum too, because you'll get a wide variety of people. We've had, dental, people from public health. So, sometimes there's questions that we don't know everything by any means. So it is helpful to have these forums where you have people practicing in a variety of roles that can offer some, recommendations, feedback, things like that.
Yeah, I actually looked through your dental resources that you guys have on, and we put some of those into in the resource tab that's in the upper left side of the video screen. We'll be listing a bunch of helpful links that your teams have shared, and I know we've got a couple dental ones on there for people that wrote in early and asked about dental help. Okay. Our last question had to do with education, and it came in the guise of measles education. What can we do to help get education out there? And maybe I'll start with you, Dr. Rosenman, because you guys focused a lot on how to get the education, how IPs can get education, not just for themselves, but out to their the staff at the hospitals. So when you have something like measles or another sort of critical illness that or infectious disease that's coming up, do you guys have recommendations for how to roll that out effectively to the staff?
That's a great question. And talking about vaccines, but really anything that is kind of hot off the press is leveraging that, because it takes a topic that maybe people are a little bit hesitant to talk about, or we're a little gun shy around right now, but now we're finding patients or healthcare workers coming to us with questions about it. And so making sure we use that opportunity and that we're prepared, right? We're prepared with the facts. We're prepared with good resources, reliable, credible resources in the moment, so that we can seize it, kind of that teaching opportunity if it presents itself. So in some ways it might help move the needle a little bit. And I think we've talked a lot about kind of with IPs about getting comfortable with difficult conversations. So practicing it, like this is really low cost stuff to practice kind of role play. We try not to use the word role play because people like scatter when you say role play. But if you go through it once, fumbling through those words, then getting through it in real life becomes so much smoother. And so know your resources, know what's credible, and then practice the language you're going to use, and then kind of recognizing where people are and whether they're going to be receptive to that information. So I'm not sure. I mean, I think the question you asked is much bigger. Like, how do I don't have anything specific about holding a seminar or webinar specifically on measles. Although, when something like this hits the news, I think there is room for that, right? Where there might not have been room for that a year ago. So that would be. I don't know if anybody wants to contribute to that answer.
I think the other thing that came up quite a bit when we were talking to our participants is really, I think there's a lot of people that we don't think of as typical clinical staff that still are frontline healthcare workers, like people who work in security, people who work in registration, front desk workers at clinics. And I think it's really important to recognize that they can also be a partner for early identification of people who might be sick, who might have something contagious in our waiting rooms. One thing that came up is I think a lot of those people felt very anxious during the COVID pandemic, and maybe a little bit less of the education was directed towards them initially around PPE use and thinking about transmissibility of COVID. And so I think really including those people and those healthcare workers in the education would be very helpful.
That's great advice. Oh, go ahead.
Oh, I'm sorry. I guess just to share things that we have done as well. We used to work with a provider who said, like, never waste a crisis. And this really is like a great time to like get in front of your colleagues and to, share your knowledge and to understand what their concerns are. One thing that we found really helpful, especially really early in the pandemic, was going to staff huddles. If your nursing units are doing that, REVS also had staff huddles. So we would go and do quick PPE, just in time training sessions. So I guess my biggest piece of encouragement is when you have things like that, like really get to your staff's level, see where they're coming from, where they're at with their knowledge base, and then you really have a place to go off of.
No, thanks, Lauren. That's exactly what I was going to say is recognizing who some of the champions are in these areas and understanding that they will be your best advocates in helping you get the word out and putting up signs or posters or those kinds of things and making sure that everybody has access to the same education. So I want to thank everybody, all of our panelists today for sharing your experiences with us. I appreciate the University of Washington, University of Michigan physicians, to help us see what some of the needs are in rural healthcare facilities, and also the University of Nebraska Medical Center team for sharing all of those amazing resources with us today, as well as what you've got going on with your webinars and office hours. You've all done such a great, amazing work in this space, and I'm thankful that you have contributed to the hardworking IPs in these rural areas. I want to thank our audience. It's uplifting to see so many people interested in how to support IPC in rural areas. These might be small facilities with limited staff, but they can have huge hearts and amazing dedication to their patients and their communities. As someone who worked in such a setting, I can attest to the passion and resourcefulness that rural and lone IPs have. Hopefully, some of the information and resources we've shared today will make your jobs a little easier. We have links to many of these great resources that we've shared in the resources tab. If you want to get CME or a certificate of completion and participation, please click on the Take Quiz button under the video screen, and you can go to amafirstline.org for more IPC information. Thank you.